Hi, good morning. I have the distinct pleasure of introducing Dr. Kowalske. Today is our annual Heimbach lecture, and I just want to say a couple of words about Dr. Heimbach. Dr. Heimbach was our director for a quarter of a century in a burn center. And I think last night when we went to the dinner with Dr. Kowalske, we talked about some of his contributions, and one of the most seminal ones was the really taking on the concept of early excision, something that took the mortality of burns from pretty much over 50 to 75% to down to 25%. So is that still on, Sarah?
You're getting a little echo.
Okay.
Better?
And so that's what kind of happened in the early 1980s through the work by Dr. Heimbach and Dr. Angrave, who founded our plastic surgery division here. With Dr. Kowalske comes the experience of the UT Southwestern group. And, I just want to say how much relationship we have with UT Southwestern. Many of our founders in our department came from Dallas. And now the burn director at UT Southwestern is a UW graduate. And now I think Cameron next year will go there as a fellow in burns. And so we have so much relationship. What Dr. Kowalske does is, I want to highlight something that's so remarkable about her, and one of the main reasons why we invited her. So I can tell you a lot about how much she's published and how she was her department chair for 17 years. But what struck me when I first learned about her work and got getting to know her is that the level of ownership of burn patients that physiatrists have at Parkland, which is so unique and something that I've always looked up to. And I hope that she's going to tell us something more about this. And that's something we can learn from. So we're so glad for you to be here, Karen. And we're looking forward to your talk.
I want to thank you guys for welcoming me here. It's a real honor. And, I do sort of feel like we're a bit of sister programs. I think our approach to trauma and to burns is very similar across institutions because of all the cross-pollination. All right, I guess next slide. There we go. So I work at UT Southwestern and our affiliated hospitals, Parkland. We have a system similar to yours where we have a university hospital where we do a lot of private cases, but we're actually on the same campus. So Parkland is 800-bed level 1 trauma center and burn center. I'm just as a disclosure, I'm the current president of the Association of Academic Physiatrists, which is the academic organization for rehab physicians, and I have no financial disclosures. I'm the principal investigator on the North Texas burn model system, and I'm going to talk a little bit about the burn model system, mostly because Dr. Pam wants me to get residents doing research. So there is a funding stream through the Department of Health and Human Services in a division called NIDLR, the National Institute for Disability Independent Living and Rehabilitation Research. In 1994, Dr. Angrave, along with Dr. Helm, my mentor, worked closely with NIDLR to establish a burn model system. So NIDLR had been sponsoring outcomes research in spinal cord injury and in brain injury for many, many, many years, and they convinced them to start one with burns. So it started in 1994 with UW and Seattle and Colorado at the time, and then we added Hopkins, and then it's a 5-year cycle. So each time there are new competitors, and the current ones are Harvard Spalding and USC. So it's a very large data set, has over 7,000 subjects in it that have long-term data over time. There's pre-injury data, acute care, and rehabilitation. Outcomes at 6 months, 12 months, 24 months, 5 years, and it's publicly available for research. So for anyone, an external person has to do a special kind of request, and we review it pretty closely to make sure that we can answer the question asked. For you guys, it's super easy. So the PI here at UW is Barclay Stewart, and you can just meet with him and get a proposal in, and we can get you going almost right away. So it really is something I tell my residents and students is that we can almost guarantee that you're going to have a publication within a year. So it's an easy way to get a project done that's of pretty good quality with good data. Doesn't mean it's not hard work, it is. The other thing it has, and when you're rotating on burns, you really should look at this, but the burn model system has a series of patient education materials. So we have little flyers that are 1 or 2 pages on pain and itch and nightmares and psychological distress and sleep, nutrition, exercise. We have videos on sexuality and return to work. We started a new thing. We learned something that was brought up from your center that most people don't read, which turns out is true in our center too, and that most people won't read more than a paragraph. So now we have info comics, which are 4 squares of just how you manage a burn complication. So those are available as well. So this is our data set. And the reason I put this up here is as a learning thing. So this is the yellow are things that we do at discharge only. The green are discharge and follow-up, and the blue is a follow-up only. If you're ever designing a large data set, don't do this, because you can see that there are a bunch of things that stopped and started, and a few that started and then stopped and then restarted. And you need to be very attentive if you're going to eliminate variables or start new variables. And you need a good reason to do that. Now, sometimes there are things that you can, like we started out with the SF36 and then the SF12, and then we went to the VR12. Well, those can be linked so that you can still use your old data, but you have to be careful about dropping out variables. But these are the kind of variables we have. And this is who's in the data set. So we have a lot of children. In the last, for 3 cycles, UTMB and Galveston, the Shrine was one of the centers. And so they had enrolled lots of children. I would say in general, our center is like yours, where it's like 20, 30% kids. And so the interesting thing we've just published, though, is that their subset of children, 90% of them come from Mexico. So it's a very different population than what we see here. So if you're interested in analyzing pediatric data, we have it, but you just have to know that there are some differences from kids who are treated in the US and returned to Mexico versus treated and live here. You can see that, like from burns, that it's 20 to 40-year-old and mostly men. But one of the things we were talking about last night is there's some things we haven't looked at. Like we have almost 100 people who are over 80, and who has outcomes of burn survivors who are over 80, and that might be a good paper to just look at. What are their outcomes? What's their survival? How do they do once they're out of the hospital? And we haven't looked specifically at that subset. So interestingly, one of our therapists likes to say that this is a chromosomal injury, but it falls in line with our other traumatic injuries, that it's mostly males. And that's true at all burn centers across the US, pretty consistently 70% men. Interestingly, around the world, it's the other way around. It's mostly women with cooking injuries, but in the US, it's mostly men. Mostly at home, mostly living with a partner, mostly employed. The alcohol history and drug use is intellectually interesting to us, but we've learned there's no easy way to collect that. And partly because we do self-report. Now, there are a couple of centers that do drug and alcohol testing. The challenge with that, so our trauma guys still do tox screens on admissions. The challenge with that, at least in Texas, is that if your tox screen is positive, your insurance doesn't have to pay for your hospitalization if it's traumatic. So if you're in a car crash or if you're injured at work, workers' comp doesn't have to cover you. And so we had someone who had cannabis in the system. Well, that could have been from 3 weeks ago, but 0 insurance coverage. So it was hurting our hospital to check their tox screens. The other thing we've had a challenge with is that we have patients who get drugs in the ambulance. They get opioids or even fentanyl sometimes, and then their tox screen is positive. So I do think you have to be thoughtful about whether you're automatically going to get drug screens. So this is their TBS range. So the model system enrollment is greater than 20% TBSA or full thickness burns of hands or face. So we have some smaller burns in there and they have to have had a surgery for the burn. So a skin graft or some other RECELL or some other burn surgery. But we do have, over 100 people with over an 80% burn. So lots of good data there on how burn survivors do. So the next thing I'm going to do is to sort of walk you through some of the latest burn research. In a way, actually, Gretchen Kerrer, who's online, is a nurse who's been here at Harborview forever and done lots and lots of really good research. So this was actually her idea. She did a paper with 3 burn survivors, and they just walked through their life of after their injury. And we talked about how the science changed their outcome. And I do want to challenge each of you that you have to keep up with the science and you have to practice medicine based on the science and you have to offer that information to patients. So I'm going to go through this case and just talk about some of the rehabilitation and functional outcomes and how we use that to educate patients and sort of help them in their life trajectory. So he's a volunteer firefighter, 51 years old and married, supportive wife, was in a house fire. He's a volunteer firefighter, 55% total body surface area burn, had a trach, numerous grafting procedures, amputation of all of his fingers, 156 days in the hospital, 96 in acute, and 60 in rehab. So I know Dr. Esselman is on. I think there are not enough physiatrists on this call, but I am going to make a big speech here about how Dr. Pham validated my entire career. And that is, when I see a patient on burns, I am looking for a reason for them to go to inpatient rehab. I'm not looking for a reason for them not to go. And if you look at nationwide, most burn patients, even big burns, don't go to inpatient rehab. And I think some of that is physiatrists see them and they're confused or doing some walking. And so they're like, oh, they don't need rehab. But they have so many other goals. There's a study that looked at intake to rehab, and burn survivors come in with a cognitive score 10 points on a standardized scale, less than the rest of the general rehab population, and leave 5 points better. So what that tells me is that they have delirium, and you clear their delirium by a good sleep-wake cycle by getting them off of some of their narcotics. And, you know, we actually do a system where if someone is a big burn and their hemoglobin's low and their nutrition is down, then they'll come to inpatient rehab for 2 weeks, get stronger, and then go back to acute care. So the study by Dr. Pham compared our 2 centers. Can I disclose this? So, you know, essentially for people who are 50 to 75, for you guys, about 75% go to inpatient rehab. And for those over 80, 50% go to inpatient rehab. At our center, 90% of people over 55 go to inpatient rehab. And so it's a very different approach to look at how you're going to help maximize having people go home independently. And part of the reason that's important in burns is that if you have an 80-year-old who is delirious and has wounds and you send them to a nursing home, half of them are going to die in the first 6 months. And part of that is because they don't get good nursing care. They never get their delirium fixed. They never get their sleep-wake cycle fixed. So I think really good collaboration with physiatry to talk about why they should be managing burn patients is really important. So he had lots of complications, just like all of our big burns do. Renal failure on CRRT and pneumonia. He was on the vent. He had tachycardia. He had foot drop, HO, heterotopic ossification in his elbow, contractures, and depression. So we're going to walk through each of those a little bit. So this is him. I put this up a little bit as a teaching tool. So like you use an electronic diagram now, don't you? Yeah. So this is the old paper diagram, but the challenges of the first lines are the residents writing down the burn, and then the scratch out and the new scoring is all the faculty going back and doing that. And part of that is the challenge in burns is that when you first see it, it's very hard to know how deep it is. And that even for the most experienced individuals, it's the third day when you really know what the burn depth is going to be. So anyone can get fooled early on. So as a trainee, don't feel bad if the attending corrects all of your numbers. The interesting thing when you look on this drawing, there's almost nothing on his face. And that just was not true. So this is him, and you can see he lost part of his nose. He lost part of an ear, partial thickness on his back. These are his hands. So he lost all of his fingers on both hands. He had HO in this elbow and an open wound over the bursa, which took forever to heal. So some outcomes, his tachycardia and renal failure improved. His foot drop got better. His depression got better. He did eventually return to work, and I'm going to talk about that separately. independent, able to exercise, drive, and work in his yard. We were talking last night that there's a very famous burn surgeon who was doing a talk with me about burns as a chronic condition. And he's like, if I do everything right, when they leave the hospital, they don't need anything else. And I'm telling you, that's absolutely not true. And you need to think in a very different mindset. So I'm just going to go through some of the research impacts. So the first thing is hypermetabolic syndrome after burns, which is the increased catecholamine response. There have been a lot of studies of these. The original ones were done in children out of the Shrine in Galveston, looking at patients with more than a 20% TBSA. And essentially, the catecholamine release results in increased metabolism, loss of muscle mass, increased fatty liver. So the initial studies were all done with growth hormone, which the internet says is cheaper now, but still $500 to $1,000 a day. Oxandrolone. So if you're ever doing a journal club, oxandrolone is now off the market, but it's philosophically interesting. It's a pure anabolic steroid, like absolutely banned from the Olympics or anybody ever using it in that context. And it really did facilitate wound closure and improve muscle mass. But the big article that was in the New England Journal of Medicine that everybody says is the randomized controlled trial that proved oxandrolone worked was on length of stay. And my challenge with length of stay in any study is there's so many factors that go into length of stay that don't have anything to do with what you're doing. It's like, do they have family at home? You know, how far away from the burn center do they live? What's their insurance? Can they get supplies? And all of those other things. So I think of things to try and prove that your drug, they didn't look at increased muscle mass, which we know an anabolic steroid is going to do. So I actually use this drug a lot. They took it off the market because they said it caused liver toxicity. Well, in 30 years, I only had 2 people who bumped their LFTs. I think it went off the market because it wasn't making any money in the closing factor. So now what do? We got to do some old-fashioned things to try and modulate this hypermetabolic response. And these are the things we did for him. The first thing absolutely was what Dr. Heimbach pioneered, get the wound closed. The sooner you can get the wound closed, the sooner the hypermetabolic syndrome goes down and the better the patient's going to do. Good nutrition. All these patients are on enteral tube feedings trying to maintain their nutrition. In the olden days, everybody left the burn unit skinny, and now everybody leaves the burn unit fat. And so I think we really are doing a much better job with nutrition. There is a caveat to that, though, is that you take young men who are manual laborers and you tell them they have to eat all of these extra calories, and you never tell them when to stop doing that. So you send them home, they're not quite ready to return to work, and they're just eating all the time and not doing any physical activity. So you have to sort of talk that once your skin is closed, your metabolic needs start going down and you don't necessarily need all those extra calories. The other thing that's interesting is good blood sugar control. So there certainly is the stress-induced hyperglycemia, particularly in the elderly, and getting good control of blood sugars. One of the things we looked at was the rate of diabetes after burns. And it turns out that the rate of diabetes is higher, but there's this whole subpopulation, at least in Texas, that have diabetes and don't know it. So they come in and they're like, the burn caused my diabetes. I'm like, your hemoglobin A1C was 13 when you came in. I don't think the burn caused the diabetes. I think you had diabetes and you didn't know it. So the most interesting one to me, though, is propranolol. So, pennies a day to reduce heart rate and decrease the hypermetabolic response. And it works surprisingly well. There are now many good studies on it. When it was first studied in children, and everyone was nervous about studying in adults, and it turns out it's relatively safe in adults as well. And everyone was like, well, we won't know if they're septic, but if they're septic, they drop their blood pressure and you recognize it. So I don't think it's dangerous. The challenge we have is that nobody really knows how long patients should be on it. And I don't know if you have a protocol, but essentially for me, if they come into clinic and their heart rate is 80, then they probably can come off it. And they come into clinic on propranolol and their heart rate's still 95 at rest, they probably should stay on it for a little longer. So we sort of do it based on what their heart rate's doing. The other thing that's interesting is we've done a study that looks at early exercise. And so that if you can do exercise, you can lower the hypermetabolic response and decrease muscle mass loss. So we had this national trial of kids and adults of adding additional exercise to traditional PT and OT. So it's 20 minutes twice a day of using an ergometer with your arms or your legs. The kids did fine. The adults got too tired. You know, the longest we had anybody enrolled was a month, because after a month, they're like, I just can't do this anymore. I'm just too tired. And so I think it's a hard thing to do to get additional exercise in our adult burn survivors. Neuropathy. So our first study of neuropathy, we had one center that had a rate of neuropathy of 3% and one center that had a rate of neuropathy of 15%. Two centers that are very similar, located in two different parts of the country. And one of my friends said, what does WNL mean? It means we never looked. And so part of what you can tell is if you look at the slide on the right, you know that person has foot drop, right? I'm like, oh, look, they have foot drop. What do you notice about the foot on the left? So this person also has a perineal neuropathy on the left, because they should be able to pull the big toe up out of the plane of the other toes. So this is a milder version of a perineal neuropathy. And if you don't look close enough, you're never going to see that. So it is one of those things. If you look across studies where they do electrodiagnostic testing, you do very good physical exams. The rate is for this burn model system group, which are the bigger burns, it's really about 12 to 15%. So I would say for your bigger burns, you really do have to look for neuropathy or you're not going to find it. We did electrical etiology is about a fourth. It's always axonal, and I think it's an ischemic mechanism. There's also this generalized peripheral polyneuropathy, which looks exactly like critical neuropathy in the elderly and the critically ill. Most recover unless they're diabetic. We tried to do a study of doing electrodiagnostic testing on this patient population. And it's interesting sort of how things go with studies where you want to look at people. It's why we want to study animals and not people, because people just mess up your studies. But we paid them $100 to do electrodiagnostic testing when they're out of the hospital. And we offered them $200 to repeat it at a year. And of the 12 subjects we had, only 2 would let us repeat it at a year. They're just like, I'm tired. I don't want you to stick me. I don't want any of those studies. So it ends up that you have to use your clinical knowledge. The interesting thing I will tell you though, and is there's some new things with, particularly for the plastic surgeons in the room. So we had someone with a high voltage electrical injury with a median neuropathy in their forearm, and he could actually tap out where his Tenel's was. So we do electrodiagnostic testing, and the median doesn't conduct past the forearm. But we were able to combine that with ultrasound, and so you could actually ultrasound the nerve and see where the entrapment was in the forearm. So you could see that there was scar tissue in the muscle entrapping the nerve in the mid forearm. So we could just put a big circle there and send a note to plastics and say, you know, you don't need to explore the carpal tunnel. That's not where the entrapment is. The entrapment's up here in the forearm. So the combining of electrodiagnostic testing with ultrasound is really the way to go now for localizing neuropathies. Heterotopic ossification. Interestingly, 3 to 5% of major burn injuries, and almost all studies come out the same. There was one study out of San Antonio that had a very different number. And they had a rate of 40% of HO in their population injured in the theater, so injured in the military. Their civilian population, they treat some civilians too, 4% rate. So there's something about having a traumatic injury, which seems to predispose to heterotopic bone formation. The interesting thing is that couple of points on this. When you're reading the literature, go back to the original literature. Oftentimes what happens, extra bad now, like someone quotes something and then it gets quoted somewhere else and it gets quoted somewhere else. And you're quoting the third source and not the original source, and the original source didn't say that. But the original paper on heterotopic ossification and burns was in 1965, Basil Pruitt, who's the grandfather of all burn care. He wrote a series of case reports. There were 7 cases of HO, and he described their injuries and what they were doing and how the HO formed, and it was always in the elbow. And his conclusion was they were burned above and below where they developed HO. So I'm certain over-aggressive therapy causes HO. Well, 5 years ago, people were still saying that. They were blaming the therapist for HO, and that's absolutely not the case. That if you look at who gets HO in burns, it's all people who are missing therapy. They all have boggy edema at the elbow. They're sick. They're missing therapy. And it's interesting, we had one OT who was really, really diligent sort of our version of Beth Costa. And in 2 years, we didn't have any, we had some people develop HO, nobody fused. And so it really is about keeping people moving. And that's essentially what the firefighter did, is that by keeping the joint moving, it won't fuse, and over time the bone can remodel. My other point about HO is that you have to, so two things. First of all, the therapist is going to know it first. They're going to have a lot of pain with range of motion. The first x-ray may be negative. But the other thing is that you have to look at the x-ray yourself, because the radiologist won't see it. But if you look at the haze around the joint space, you can see the bone on this x-ray, both anterior and posterior. So look at the x-ray yourself. The other thing we found with burns is that once their skin is closed, you can resect it and it won't come back. The other populations that get HO, brain injury and spinal cord injury, you have to wait at least a year for the bone to mature before you can resect it. And I think that's because their underlying pathologic processes don't necessarily go away. The other thing that was interesting is we did a study looking at the spinal cord of people with spinal cord injury, thinking they'd develop HO in the plane of, they were doing imaging of the cord, and we're like, add in the pelvis so we can see it. And we thought they'd get HO in the plane of bleeding, and they didn't. They got it in the plane of edema. So there's something in edema fluid that's probably causing HO. So lots of things we can, and none of the treatments work. We've tried bisphosphonates, we've tried indocin. The only thing is prophylaxis. So you can do prophylactic radiation, which no one wants to do over burned elbows. The indocin probably works prophylactically, but once they have HO, none of the drugs work. So we got to keep them from getting it. But if they do get it, keep them moving, and then you can resect it early. Contractures. So here's a story of the failure of the burn model system. I can hear Gretchen screaming at me. So we set up to measure contractures. And we said that axillary contractures are the most common, and plantar flexion contractures are the most common contractures after big burns. Correct. The challenge is that we looked at all comers. We didn't see if you have, so we say, oh, 15% of people leave the hospital with an axillary contracture. Well, that's of all comers. If you just have a hand burn, you're not going to get an axillary contracture. So when you're designing data collection, you have to, oftentimes you get in a big room of people and you're just picking out variables and you're not thinking through the consequences of what you pick. Because I think we need to redo the study and really look at body part burned, location of burn, and rate of contracture in the same view, so that we can try and compare what the true rate of contracture is. Obviously, burn depth is going to make a huge difference in this. How soon you can get their skin closed. Positioning, we do lots of splinting, lots of casting, lots of ways. I love casting because I like force compliance. So there are really lots of ways to try and get people in a good position and keep them there. The challenge is that patient factors make a big difference. We wanted to see if paraffin, which is a warm wax patients love, helps them stretch, whether that changes the outcome after axillary contracture. So we randomized a crossover trial, lotion and stretching, paraffin and stretching. So they get therapy 3 days a week with one of the modalities for 2 weeks, and then we switch over. The problem is that patient A had paraffin and stretching and went home with 138 degrees of motion at the axilla and came back 2 days later with 90. And patient B had the same treatment, same range when they left, and they came back with more range, because outcome of contractures is about what you do outside of therapy, not what you do in therapy. So this, we had a funny study where we looked at how much therapy patients get and reconstructive surgery. And it turns out the more therapy you get, the more likely you are to have reconstructive surgery. And you're like, what? Therapy doesn't work? It's like, no, that's not the case. The answer is that if you're not doing your home exercise program, you have to have more therapy. That the person who's really compliant and doing everything you ask them to do doesn't need as much therapy. And obviously, contracture releases are a mainstay. One other interesting thing about contractures, so we published a study. We looked at plantar flexion contractures of burn patients in the ICU. And we used Botox to block their plantar flexors, followed by serial casting without recurrence of their tightness. So it's not an approved indication. So we can get it in the hospital because nobody cares. It's very hard to get it as an outpatient. But it's one of the things I want to study in this guy, because I think what happens first is they won't let you range them, and then the skin gets tight. So if they couldn't resist range of motion, you'd have a better result. So my next proposal would be when you're doing an axillary contracture release to Botox the pec and the lat and see if you have a better outcome. So I think that there are some interesting things that we could do with Botox. There was a presentation at ABA this last year of Botoxing sternocleidomastoid with neck releases to try and help maintain the range of motion. So I think, and Botox is a nice product because it lasts 3 months and then it wears off. So it's a good thing that you can use temporarily. Return to work. Gretchen is listening in, and we've studied this a bunch of times. I think we've done 3 papers on return to work, and each time our predictors were different. And I think part of that is we probably weren't studying the right things. So the things we know that predict return to work is working. So that's the first one that always comes out. If you're working before, you're more likely to be working afterwards. Some of the other ones, though, one time it was TBSA, one time it was amputation, one time it was the type of work you did. But it turns out that the reasons people return to work are sort of threefold. One, you need the money. One, you like your work. And I forget my third one, but you like to be busy. So if people don't want to go back to work, you can release them to go back to work, but they won't go. So you have to have some sort of compromise. And interestingly, in our most recent paper, Gretchen, if you're listening, we need to do a letter to the editor because we looked at return to work. And in this one, it really was about substance abuse was not a factor, married was a factor, and liking your job was a factor. But one of the things she did in this paper was she looked at the different sites. And what's in the data, but not in the conclusions, is that UW's return to work data was twice as good as Dallas and Boston. Why is that? Well, they have a vocational counselor in clinic. Well, she retired now, and I hear she's not being replaced. She is. So I can give you the data that says why she should be replaced. I mean, 2 times as many, not just 20% more, 2 times as many people go back to work at your site versus at ours for populations of the same age, same TBSA, same very similar burn care. And so it's one of the things we're starting to do now within the model system is to look at the different centers, because even though we're mostly alike, there are some things that we do differently, just like the number of people who go to inpatient rehab is very different between the sites. So we're starting to look at those different things to try and make sure that we see these kind of factors that say, I need to go to my institution and say I need a vocational counselor in my clinic. Amputations are a very common complication after burn injuries. 5% in flame burns, 15% car crashes. We're writing this up right now, actually. And we're going to look, interestingly, many more people have burns in car crashes in Dallas than they do in Seattle. So we're trying to pull like the traffic data and that type of thing. I think people in Dallas drive faster. I don't know. And we have bigger stretches of highway. I'm not exactly sure, but it may be older cars. So we're going to be looking at all the factors that may be causing that. Yeah, they catch fire on their own without being in a crash. The interesting thing is that we looked at having just a burn, having a burn that required an amputation, and having a high voltage electrical injury that required an amputation but didn't really have a very big burn. So if you have a high voltage electrical injury with an amputation or just a burn, length of hospitalization is the same.